Good morning, good afternoon, good evening, everyone. Welcome to another one of our webinar series organized by the International Institute for Primary Healthcare. My name is Dr. Abinat. I serve as the director for the Institute. And today I have the greatest honor to introduce to you our webinar on integrating SRH services into primary healthcare, with our moderator being Dr. Awakat Aso Tabajja, who's a senior public health expert with over 23 years of experience in sexual and reproductive health rights, health system strengthening, humanitarian response across Ethiopia, Nigeria, and Afghanistan. Currently serving as SRHR and Health Systems Advisor at UNFPA Ethiopia. He advises on policy, high-level programmatic issues, focusing on integration of SRH, gender, peace, and humanitarian factors into the 10th country program. Dr. Awaka has held his leadership role at UNFPA, AMREF, Health Africa, WHO, and the Ethiopian Ministry of Health, where he led multi-sectoral programs, secured diversified fundings, and built strong partnerships. He holds a medical doctor degree with Masters of Public Health and Masters of Business Administration, and is committed to advancing health equity and reproductive rights, especially for marginalized communities. He is a member of the Ethiopian Medical and Public Health Association and contributes to several national health policies. It's a great honor to welcome him and our line of panelists, and I welcome you to enjoy this webinar. Thank you. Back to you, Dr. Awaka.
Okay, thank you, Dr. Abinat. It's really a pleasure to be the moderator of this session, where we have distinguished ladies, to present, their experience on integration of SRH into primary health care, at global level, at regional level, and also at national level. Just before introducing them, I would like to say a few words about, today's webinar. As you know, SRH is vital for health, dignity, gender equality, and sustainable development. Primary health care is the most inclusive, equitable, and cost-effective route to achieving universal health coverage elsewhere in the world. Integration ensures continuity, accessibility, and people-centered rights-based care. It also supports global frameworks, including SRH's ICPD plan of action and universal health coverage commitments. There are different examples, across the globe about integrating SRH into the primary health care. If we take, for example, in Ethiopia, we have the Health Exchange Program, which offers family planning, maternal health, and youth-friendly services in an integrated mode. In Rwanda, community health workers distribute contraceptives and link clients to health facilities. In Bangladesh, in one-stop centers, healthcare providers deliver integrated family planning, maternal health, and adolescent health services. In Kenya, primary health facilities combine HIV and SRH services to improve access and efficiency. Today, we have three distinguished speakers. The first speaker will be Dr. Linia Zimemariam. Dr. Linia brings a global lens to reproductive health and data-driven development. A distinguished researcher with PhD from Johns Hopkins University and from Emory. She also leads the PMA Ethiopia project and serves as Associate Director of Research for Performance Monitoring for Action, PMA, where she oversees transformative studies across multiple countries. Her work brings evidence and action, guides policies that empower women and adolescents around the world. As a contributor to the Global Early Adolescent Study, she is at the forefront of shaping how we understand and measure empowerment from an early age. Dr. Linia's expertise offers a bold vision for how data and innovation can accelerate progress in SRH worldwide. The second speaker will be Dr. Roslyn. Dr. Roslyn is a leading advocate for country-led health transformation in Uganda. As technical advisor for reproductive health, family planning, and self-care at the Ministry of Health, she champions primary health care and innovation of universal health coverage. With over 18 years of experience across governments, academia, and the UN system, she's widely respected for her impact on maternal health, HIV prevention, and health system strengthening. A PhD holder and honorary lecturer at Makerere University, she serves on global expert committees and has been nationally recognized for her leadership in preventing mother-to-child transmission of HIV. Dr. Roslyn's work exemplifies how country ownership, leadership, and innovation can deliver life-saving results for women and girls. The third speaker will be Ms. SRH Balaina, with over 2 decades of visionary leadership. Ms. SRH Balaina offered deep regional insight into advancing SRH across Africa, with a particular focus on Ethiopia. As a regional advisor to the Global Reproductive Health Initiative, she steers strategy and partnership to strengthen systems and communities. Her past leadership as the foundation's representative in Ethiopia helped shape national priorities in the reproductive health, youth empowerment, and social inclusion. Knowing for building strong bridges between donors, government, and civil society, she's also serving on the Amref Health Africa International Board and advises institutions committed to inclusive development. SRH's voice brings ground wisdom and regional foresight that inspire action and collaboration across East and West Africa. So, saying this, the first presenter will be Dr. Linnea, Associate Professor from Johns Hopkins University, and her presentation will be Global Perspectives on SRH and Primary Health Integration. So each presenter will have 10 minutes to present. Then we'll have a very short, around 10 minutes question and answer for each presenter. Then we'll move to the other presenter. Maybe you can correct me if which modality is better. Shall we have Q&A after each presentation or Q&A after the 3 presentations? Maybe Bru can advise me.
Yeah. Thank you, Dr. Awaka. So the Q&A will be at the end of all the 3 presentations.
Okay, that's great. Okay, so let's go to the first presenter, Dr. Linnea. Over to you.
Great, and thank you so much for that very kind introduction. So my name is Linnea Zimmerman, and I am an associate professor in the Department of Population, Family, and Reproductive Health at Johns Hopkins, and I am presenting from Baltimore. So it's not very early in the morning here, but early-ish. So good morning, good afternoon, good evening to everyone. My task, let's see, this is not advancing. Okay, so my goal for my presentation is to really set the stage for what we mean by SRH and primary healthcare integration. So I'll start with sort of a general overview of the goal, as well as provide some examples and considerations, and end with links to some tools. So when we are talking about sexual reproductive health and primary care integration, I wanted to take a step back and just discuss that overall goal. And really why we're here, why we care about this is that we hope to improve population health and the health of individuals by ensuring universal health coverage. And this idea of universal health coverage is that all people have access to the full range of quality health services they need, when they need them, where they need them, and without financial hardship. And this is the definition provided by the World Health Organization. And universal health coverage was really gaining a lot of momentum prior to the COVID-19 epidemic. And I think that really demonstrated for everyone, COVID-19 really demonstrated for everyone the importance of the primary healthcare system as a major responder and provider of healthcare. So this discussion of integration of sexual and reproductive health has then really taken on more importance in the past few years. And what do we mean by sexual and reproductive health? There's not necessarily one standard definition of what fits into sexual and reproductive health. Different organizations, nations, individuals might qualify different things, but in general, we think of sexual and reproductive health as including maternal and perinatal morbidity and mortality, gynecological cancers or other reproductive health cancers, sexually transmitted infections and HIV/AIDS, and unsafe abortion. And while most of what I just said is generally specific to women or females, it is important to highlight that males and gender diverse individuals also have sexual and reproductive health needs, and those largely may fall into sexually transmitted infections, HIV/AIDS, and cancers. But I just want to highlight that because while we will largely be discussing sexual and reproductive health needs for women, I do just really want to highlight that all individuals have sexual and reproductive health needs, and it's important to consider those needs as well as we integrate into primary health care. So what do we mean by SRH integration? Essentially, we're thinking of elements of sexual and reproductive health, so those that I just listed, maternal and perinatal morbidity and mortality, cancers, etc., that do not require highly specialized secondary level care, that those services are available at one and the same service delivery point, and that they're easily accessible and person-centered. So it is important to note, not all elements of sexual and reproductive health can be integrated at the primary healthcare level. And those would be things like highly specialized maternal care, perhaps delivery care, comprehensive emergency care. Those things do require specialized care. Potentially cancers once they are diagnosed. But there are certain elements of sexual and reproductive health that can be delivered by non-specialized care, and that's contraception and abortion care, noting that abortion access does depend on legality of services. STI screening and treatment, particularly curable STIs such as chlamydia and gonorrhea, and non-specialized pregnancy care such as antenatal care or postnatal care, as well as certain vaccine services such as HPV vaccinations. Ideally, these necessary and basic preventative and curative services can be offered at the same time or at least within the same facility with limited need for specialized care so that individuals can come in to one provider or one facility and be able to access their needs on the same day, ideally at the same appointment. And the reality is that most services for people are often provided by fragmented specialists. They're available on different providers on different days and sometimes in different facilities. And that's what we want to avoid. And that's why we're having this discussion about integration. So integration can really take several forms. I'm just listing 3 different examples here from different locations to kind of give a flavor of the different ways integration has occurred. So the first is an example of curable STI screening and treatment being integrated into primary healthcare in Europe. And most of this evidence really comes from the UK, but this example was particularly looking at chlamydia testing that was integrated into all primary healthcare appointments across different settings in Europe for both women and men. And just noting that the acceptance and coverage was higher for women, and this goes back to my point a few minutes ago about SRH being needed for both men and women. Acceptance and coverage was generally higher for women because women were more likely to receive screening and treatment than men. And so again, just highlighting that we really do want to think about the needs of all people and how we can integrate that into primary healthcare. Then we have contraceptive services that are integrated into ANC antenatal care, post-abortion care, and immunization services. And Ethiopia has really been at the forefront of this. I think most likely one of our examples, or one of my other panelists will speak to this. But Ethiopia has really been at the forefront of integrating contraceptive services into a wide range of services. But one of the limitations has been that there's significant gaps in the number of providers who are trained in family planning. And what I mean is not family planning providers, but providers of maternal and newborn care or post-abortion care or immunization services. There's gaps in the number of those providers who have been trained in comprehensive family planning. So again, a consideration to think about. And then this last example, often when we think about integration, we think about integration at the point of care, but integration can happen at multiple levels. And one of those is at the sort of at the policy or insurance scheme level. And so in multiple settings, and I just list 3 here of Kenya, Nicaragua, and Thailand, sexual and reproductive health services, and generally contraception and abortion, although these have been expanded elsewhere, are integrated into health insurance schemes that cover primary care. And this is an important consideration when thinking about financing. So what does it look like now? What does integration look like? So the essential package of health services is what's generally used to guide the design of primary health care. And there was a recent review that identified that most essential packages of health services do include family planning and maternal health, but many fewer include things like breast cancer screening, infertility screening, gender-based violence, and safe abortion, all of which we can consider as sexual and reproductive health needs. And so we are making progress on certain fronts, but there are others that are being left behind. Then we have fewer health insurance schemes, either public or private, cover all contraceptive methods or ensure the coverage of the broad range of contraceptive services. They may generally cover only short-acting methods. There tends to be limited financial investment in sexual and reproductive health relative to other investments in the health system. And then there's particular challenges for adolescents, and this includes provider bias about the kinds of services that adolescents should be seeking. There may be restrictions on care about the kinds of services that can be offered to adolescents. And then there's a particular piece, and this again will vary by setting, but if adolescents are covered under, at first, there may be parental disclosure requirements for adolescents, but also if adolescents are covered on parental insurance, then they may be informed about adolescents seeking care. And so all of these are particular SRH integration questions that impact adolescents specifically. I realize I only have about a minute left, so I'm going to go a little bit more quickly here. But these are just some of the considerations for integration, and these are also listed in one of the tools that I will link to at the end. But considerations are, what are the legal or policy frameworks that inhibit or support integration? So what levels of providers are able to offer services? Are providers legally able to offer services, such as age restrictions or marital restrictions? And what services are covered by insurance? Then there's the questions of, are financial systems able to support integration? Does procurement for commodities operate centrally or by service? Are providers able to charge for multiple services? And particularly, I'm sure as many of you know, there has tended to be siloed charging and procurement of HIV versus family planning commodities. So how do those operate to limit integration? And then I'm going to go to just my last 2 slides here are just thinking about some of the research, data, and evaluation considerations. So first, I would just highlight that there's really a need for studies to establish effectiveness, patient satisfaction, and health outcomes for sexual and reproductive health integrated into primary healthcare. Most of the evidence on integration is SRH integrated into other SRH, as opposed to into primary healthcare. And as we face a limited data landscape in the future with the closure of the DHS and limitations of other health facility surveys, it's really important to think about how we can have HMIS systems that can be more readily utilized to monitor integration. And I'll be happy to speak to this later on in the Q&A, but how can we use some of the data we have to really think about monitoring and evaluating our progress towards integration? So in my last slide here, these are just some of the tools and resources that I would really encourage people to look at and review. There's an entire volume on sexual and reproductive health matters that was published, I think, 2 years ago that looks at specifically integration. And the WHO critical considerations is where I drew a lot of this material, and it really provides a step-by-step guide to think about how to integrate sexual and reproductive health in primary health care. So those are my last slides. Here are some of the references. We will be sharing the slides, so everyone will have access to all of these. But that's it, and thank you very much.
Thank you, Dr. Lini. Just you finished on time. So Dr. Lini, actually, she told us the global perspective and country perspectives of SRH into primary healthcare integration. She mentioned few countries like Ethiopia, who is leading, in terms of integration of SRH into other healthcare services, followed by Kenya, Nicaragua, Thailand. Especially on integrating antenatal care, postnatal care, post-abortion care and immunization. And she also mentioned, the global state of integration, especially, related with insurance, health insurance schemes, issues related with SRH policies, and the challenges related with access to adolescents and use, for SRH services. So she also mentioned, for consideration, in different countries related with legal and policy frameworks on SRH, because SRH is really sensitive. And there is also financial related constraints for SRH, because SRH, especially in lower and middle income countries, are donor dependent, and especially the domestic and other innovative financing mechanisms should be considered. And other consideration is the capacity of healthcare providers to provide integrated SRH services, and the other one is research, data, and evaluation, especially data on integration of SRH into primary healthcare is limited. So these are actually some of the points that she raised, but she also shared the references that for our reading. It was quite comprehensive, and thank you, Dr. Linnea, really for the insightful and informative presentation. Thank you. So the second presenter will be Dr. Rosina from Uganda, who is a technical advisor for SRH, family planning and self-care, Ministry of Health of Uganda. And her presentation title is Sexual Reproductive Health, Integration into Primary Health Care, in considering the experience from Uganda. Over to you, Dr. Roslin. So you'll finish at 3:34.
Okay. Thank you so much, moderator. I take this opportunity to welcome everyone. My presentation, as already said, is on Uganda's experience on integrating sexual reproductive health into primary health care. This is the outline of my presentation. I'll look at the definition of the concept, SRH indicators in the country, the progress so far, and the challenges that we go through. I just want to re-echo the fact that reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And this is in all matters relating to the reproductive system and to its functions. Sexual reproductive health is a public health issue, social justice, and human right. In Uganda, we actually call it a developmental issue because it empowers individuals, it gives them the right to information and services to be able to make a decision. By way of giving you statistics of our country. This is how our population trend has been. From 1911 to 2024, we've grown. We are now about to make 60, but we are still at 45.9. This is a key indicator still. Our fertility rate in the country is still high, 5.2, and this has disparities between urban and rural, as you can see in this slide. Our modern contraceptive prevalence rate is 38.5%, and this increased from the 2016 UDH to now 38.5, with unmet need of 22%. Our antenatal coverage is still low. In the first trimester, we have only 36%. But for focused antenatal with fourth visit, we have moved at least to 72%. Our maternal mortality ratio in the country has been gradually improving. From 336 in 2016, we are now at 189. And the institutional maternal mortality ratio is at 90.3 per 100,000 live births. According to the Sustainable Development Goal, the country targets, we are working towards realizing the target of having 70 maternal deaths per 100,000 live births by 2030. We still have high teenage pregnancy, as you will see in my child days ahead, which is stagnated at 25, but now we are at 24. And high sexual gender-based violence involving intimate partner violence at 16%. And our HIV is still bad. We have new infections, which is contributed to by adolescents, where we have 1/3 of the comprises 1/3 of the total infection in the country. This is just more slides to show under 5 the infant, but our girls start the sexual debut at 17 years, and our institutional deliveries has moved from 25 in 2011 to 91 now, with the HIV prevalence, as I said, 5.4, and our life expectancy has really improved to now 65. My slide is no longer moving. Is it moving that side, moderator? Okay.
Yes, it's moving.
So so overview of our SRH in the country. Uganda faces significant challenge, and this is contributed to limited access, particularly by the young people. And even though we've made progress, but we still have challenges that exist in as far as access to information by the young people on contraception and addressing the social norms. In as far as emergency response is concerned, Uganda hosts over 1.6 million refugees, making Uganda the 3rd largest in the world and the leading refugee hosting country in Africa, with over 80% of the refugees comprising of children and adolescents. And in these settings, family planning is not, or SRH as a whole is not prioritized, because governments look at shelter, food, security as key things, and yet there is high teenage pregnancy. So with all this, we've had a bit of progress that government policies and strategies that are in place has helped address SRH issues. We have national and international partners who are supporting government in implementing SRH and ensuring integration. We have improved access to contraception and community outreaches that have been supported by most of our partners, and generally involving stakeholders like the religious, cultural leaders, among others. In this slide, it's showing the progress still that under infrastructure, we've done a lot. We have deployed midwives at the BEMO facilities. We have adolescent responsive services in the country. We have procured over 212 ambulances to support in maternal health, and established a quality of improvement center, which is seated at the Ministry of Health. In as far as leadership is concerned, there's good coordination and accountability. Every week, we audit any maternal death in the country. And we also have regional technical teams that help in reviewing these maternal deaths and offering technical assistance to the medical doctors and midwives through the local maternity neonatal systems. We also have commodity security action groups comprised of pharmacists in the regional levels who also help us in ensuring that we have commodities that are required. And as a country, we started annual conferences on safe motherhood that brings different stakeholders to discuss different SRH issues, family planning, we have self-care, we have maternal health as a whole, and abortion care. Yeah, under financing, we have through public-private partnership by supporting community. Yes, thank you. And then the results-based financing that the country has been engaged in, and of course, advocacy for domestic resources through the different advocacy groups. And as far as human resources is concerned, we've revised the human resource staffing norms where we've increased critical cadre for maternal newborn health and implemented the clinical mentorship. We also have under medicines and supplies, our Department of Pharmacy that is supporting with the quantification, forecast and quantification, and generally managing the entire supply chain system. And we've included the IV caffeine citrate in managing preterm births, as well as carbetocin and tranexamic acid added to the essential medicines list to help in preventing maternal and birth-related bleedings, and equipped some of our facilities with equipments that they need to be able to offer services. And as far as family planning, the country is now able to procure a method mix of contraceptives, including self-injection with DMP sub-Q. We have dedicated M&E team that helps to analyze and generate report, and we use standard tools, and we are now embracing digitization where we have the electronic community health information system that captures information from the community health workers, and the weekly maternal and perinatal death review that I mentioned about, where over 800 participants tune in every week to discuss why a mother has died. And then we dig deeper to know what has happened, and we go in to give support to that particular facility to ensure that no other death occurs. This slide is showing the snapshot of maternal and perinatal death surveillance that we do in the country. You can see just in the month of April, we had 18 maternal deaths. And out of these, all of them were notified and audited, and presentation made to the MPDSR committee. And because of this, it makes the health workers be proactive and respond without necessarily waiting for another death to occur. We have also promoted strategic collaborations and partnerships. We have, through our Sharpened plan, where we have the public-private partnership and corporate social responsibility, as I said, this is helping us to advance the care for maternal and newborn health. And then we have accountability framework, which I already mentioned. We track financial allocations for family planning and maternal health, where government is held accountable. If in a particular fiscal year, no allocation of resources is made, then they are held accountable, and it preempts them to be able to allocate finances for the subsequent fiscal year. Commodity security, as I've already said, and then policy development and review that has enhanced and offered conducive environment. As far as legal frameworks are concerned, the Constitution of the Republic of Uganda provides for the right to health and protects women's rights. And this has helped us a lot, that where issues like men beating their wives or their sexual gender-based violence, it is handled according to the law. In the National Development Plan 3, it also talks about reducing unmet need for family planning from 28 to 10, and reducing teenage pregnancy to at least 15% by 2030. And HIV/AIDS Control Act is also a document that we are using because it promotes universal access to HIV/AIDS services. We also have the Public Health Act that holds Minister of Health accountable to ensure provision of better reproductive health services to women, and the National Health Policy that prioritizes reproductive health and maternal health, including HIV/AIDS control. With all that, we still have challenges like any country, that our access to SRH is still limited, especially in the rural community and by the young people. There is still high teenage pregnancy and gender-based violence. We also have inadequate comprehensive sexuality education and gaps in our policy implementation. We have myths and misconceptions that are really in different regions because of the cultural norms. For implementation of these policies and legislation, we have good policies in place, but they are not implemented. Stagnating teenage pregnancy is a big issue for us. Low family planning uptake, limited access to quality services is still an issue, and the regional disparities. I therefore have this that would like to strengthen SRH education and youth-friendly services. Would like to increase funding and healthcare infrastructure, combat gender inequality and cultural barriers that affect access to sexual reproductive health, and ensure enforcement of laws that protects women and girls SRH. Finally, the call to action to government of Uganda is to embrace fundamental human rights, to access to sexual reproductive health, and also having multi-sectoral approach, because sexual reproductive health is not just a medical issue, it is also a developmental issue. I want to say thank you so much for listening to me.
Thank you, Dr. Roslyn, for the informative presentation. As you have heard, she has shared us really very important experience from Uganda. Actually, as pointed out, Uganda actually it was, the population of Uganda in the early 90s was around 2.5 million, and now you have seen how the population has grown drastically, and the fertility rate is high actually, which is about 5.2. But other indicators have seen that they are really better than many African countries, like especially in the sub-Saharan Africa. Like the MMR is really doing good. If I'm not mistaken, it's like 90 per 100,000 live births. So that's really very promising. We have also seen that Uganda is one of the third country in terms of hosting refugees, which I think may be a point of discussion how Uganda is managing the humanitarian development and peace nexus initiative, integrating the refugee with the host communities. Maybe you can share light later on during the Q&A sessions. So we have also seen how the SRH program in the primary health care services actually progress in terms of infrastructure, health financing, leadership and governance, human resource and medicines and supplies. So we have also seen how they are really tracking the data, the finance, and the commodity security. And she has also shared us some of the challenges which are most similar to other African countries. So thank you, Dr. Roslyn, for the informative presentation. So the final presenter will be Dr. SRH Balaina. She will be presenting the Ethiopian perspective, as she's also a regional advisor. Maybe she can also shed light on her experiences, with other African countries as well. So, Dr. SRH, over to you. Yes, it's feasible.
Okay, thank you, Dr. Aweka, for the kind introduction. And I also want to thank IPHC for the opportunity to be part of this conversation, very important conversation. Since the previous speakers really covered it very well in terms of definitions and frameworks for SRH, My presentation will focus on the relevance of PHC for SRH programming by reflecting on lessons from Ethiopia, which I know very well, and also highlighting experiences from Kenya and Rwanda. As I say this, I also want to recognize that many of the colleagues in this webinar bring deep expertise and experiences in PHC, SRH, and the African context. So my presentation is intended to contribute few ideas and to help spark and enrich the discussion. So again, thank you, and happy to be part of this conversation. So just to give a bit of background, I want to start by sharing an overview of health status and trends in Ethiopia during the past 2 decades, which also overlaps with the introduction and extensive rollout of PHC in the country. As you can see, between 2000 and 2019, there has been significant reduction in under 5 infant and maternal mortality. Perhaps the most significant achievement was the reduction in maternal mortality rate, where there was close to 70% reduction. On the other hand, use of modern contraceptives has increased by 6-fold. And yet, despite these achievements, there are huge gaps to reach national and global commitments. While several factors have contributed to this achievement, including progress in the non-health sector, the major inputs from the health sector were the expansion of PHC infrastructure, particularly in rural areas, which increased geographic access, the launching of the National Health Extension Program in 2003, investments in accelerated training of mid-level health providers, including nurses, midwives, and health officers, and clear policy and commitments, including on task sharing on part of the governments. This is a kind of busy slide. I apologize for that, but the purpose is to provide an overview of Ethiopia's health system and the fit for PHC. Accordingly, Ethiopia follows a 3-tier structure, which emphasizes primary health care as the foundation for achieving universal health coverage. The system includes at the primary level, which is the primary healthcare units, the core of service delivery, which includes health posts serving up to 5,000 people, health centers serving up to 25,000 people, and primary hospitals serving up to 100,000 people. At the secondary level, we do have general hospitals that serve as a referral for primary hospitals and offering specialist services and covering population of up to 1.5 million. And finally, at the tertiary level, specialized hospitals provide advanced diagnostics, treatment, and training. Overall, the key features of Ethiopia's primary healthcare system can be summarized in this graphics, which really shows that decentralized governance focus on community-based care and ownership, service integration and referral services, and partnership. I just want to pause a little bit around the issue of partnership, as it is the cornerstone of PHC programs in Ethiopia. Partnership is a key pillar for PHC program in Ethiopia, which emphasized effective coordination with global health partners and donors. The Ministry of Health has been able to effectively implement the principle of the 3 1s, 1 plan, 1 budget, and 1 report, which has really contributed for harmonization of resources and services. In addition, funding and technical support were aligned with national strategies, enhancing efficiency and impact of the primary healthcare programs. In this table, what I've tried to do was to really sort of summarize the enablers, barriers, and key results in PHC. Actually, I will not go into the details as it will take time. However, I want to highlight a few issues under the enablers and barriers category. Perhaps one of the key enablers for PHC in Ethiopia is the bottom-up approach, which goes to the lowest level of the administration, which we call the qabalis. And the highest level of political commitment was key for the program. At the beginning of the National Health Extension Program, the ministry used to have a motto where they say all roads lead to HEP, or the Health Extension Program. This was a way to really galvanize and reinforce commitment and support from all partners to the National Health Extension Program. Yet it was not without challenges. There was initial resistance from partners and donors at the introduction of the Health Extension Program. In order to tackle that, the ministry has to do consistent dialogue and engagements, trust-building processes, and commitment to improve data-driven decision-making as an approach to gauge the ownership and the support from the global public health community, as well as local actors in Ethiopia. In addition, despite accelerated training programs, there was and still is critical shortage of human resources due to high attrition rate as well as health workforce transfers. And at times, it also becomes difficult to sustain the motivation level among the community health workers, including the health extension workers. Another big challenge for the program has been inconsistent implementation of the health extension program package and weak accountability mechanisms at the community level. And of course, finance has always been a major barrier in order to cover a large country with a population of over 120 million. In addition to Ethiopia, I just want to take a few minutes to highlight key features that have contributed to the successes of primary health care programs in Kenya and Rwanda. And as I said earlier, I really look forward to hear more from colleagues in these countries. Rwanda has made tremendous success where the health insurance coverage is over 90% and CHOOS provide basic PHC services, which has resulted in significant reductions in maternal and child mortality. Key strengths for the program include strong political will, data-driven decision-making, and decentralized health governance. Similarly, in Kenya, there is a lot we can learn from the Linda Mama program that provides free maternity services through public health and select private providers. And the key strengths include public-private partnership and result-based financing. So despite differences in implementation, several common elements stand out for the three PHC programs, Ethiopia, Rwanda, and Kenya. Just to mention a few, all the three countries rely on trained community-level workers to expand access, especially in rural and underserved communities. In Ethiopia, they are called the HEUs, Health Extension Workers. In Rwanda, it's the CHOOS, and in Kenya, it's the CHVs. Another feature is commonality is decentralized service delivery, which has enabled more responsive, context-specific PHC service delivery in the countries. I think government ownership, a lot has been said around that, and all the three countries have made PHC a core pillar of the national health policy with a strong political commitment and budgetary support. And perhaps I would just say and reflect around the issue of data and the effort to link PHC with sustainable financing models. So these are some of the key features in these countries implemented during the past decades. So what is the lesson for us? Taking the lesson from the three PHC models, I just want to reflect few lessons for integration of SRHR into PHC. One is the issue of accessibility. First and foremost, community-based programs reduce barriers like distance, cost, and stigma, which can prevent people from seeking essential family planning and reproductive health services. If we take the case in Ethiopia, more than 80% of our population lives in rural places, and I believe the context is similar in most parts of sub-Saharan Africa. Hence, integration of SRH into PHC will ensure reaching the large segment of the population, including people who are most disadvantaged. Another lesson is comprehensiveness of services. Community-based programs also ensure holistic approach to SRH, including health education, counseling, management of SRH conditions. And integration is key for creating possibilities to integrate family planning with ANC, PNC, PAC, and other services offered at the community level. Contextualized care, as I said earlier, offers culturally sensitive, context-specific SRH services, enabling community engagement and promoting behavioral change. And as Dr. Aweka initially mentioned at the beginning of the session, SRHR being a very sensitive matter, contextualizing and making it culturally sensitive and appropriate is a key element to the advancement of the program. And finally, I just want to reflect on the issue of empowerment and education. As we have learned from the experience in Ethiopia, the 40,000 plus women health extension workers and health development army have shaped the cultural norms which diminish the role of women and young girls in society. In Ethiopia, the health extension workers have gained increased public acceptance, livelihood, as well as become involved in political decision-making process in addition to their role in public health. So having women health extension workers has been a great contribution to the gender equity agenda for the country. In conclusion, I just want to reflect on a few points. One, in terms of integrating sexual and reproductive health into primary health care is not merely a necessity. It's a strategic imperative for the future of equitable and sustainable health systems. Given the rapid and significant shifts in global financial assistance, the realities of the moment highlight the critical role of primary health care, which SRH integration being a key element for the success of the program. Drawing on our 3 case studies, Ethiopia, Kenya, and Rwanda, integrating sexual and reproductive health into primary health care not only advances universal health coverage, but also delivers tailored services with higher level of community ownership and leadership. PHC frameworks enable multi-sectoral collaboration and foster innovative solutions. Embedding SRH with PHC promotes financial sustainability through coordinated domestic resource mobilization, alliance building, and strategic partnership. All these elements would lay the groundwork for a lasting and sustainable programs in SRHR and PHC. Thank you very much, and I look forward to the discussion.
Thank you, Amy, for the informative and very elaborative presentation concerning experience from Ethiopia, Rwanda, and Kenya. She actually mentioned, the commonalities that the 3 countries shares. Just, I want to focus on that. The 3 countries actually they have community health workers, which is really very strong and can be a model. And actually, many African countries are learning actually from these 3 countries. There is a decentralization model. Government ownership is strong. Data and there is data and digital tools, which is really very strong in the 3 countries. Integration of SRH into other services is also very strong. And she also touched about the lessons and the pathways from these 3 countries and actually the recommendations. So we have actually around 30 minutes to conclude our meeting. Definitely there may be questions from the audience. So if I can start from Dr. Lini, just to reflect some of the questions which are reflected on the Q&A caption. I mean Q&A section. Have you got some of the questions just to respond, Dr. Lini?
Yeah, I think so. There was a question. There was a question prior to that disruption during Dr. Rosaline's presentation about framework. So I just wanted to highlight that because that question's no longer available. So somebody had asked about frameworks to guide integration, and I just wanted to, I had linked to the WHO critical considerations document. So I will try and find that again and link to that again. But I do think that that provides a very useful framework and pathways for integration and things to consider. So I will try and link that in the chat so people can access it. And then the current question is, the gap between the ideal of co-located services and the reality of fragmented care remains stark. It does. Have any low and middle income countries successfully improved the continuity of care by integrating SRH into routine primary health services such as immunization? For instance, Ethiopia's PMA data from a few years back showed only 20% of mothers complete the continuum of care. Yes, that is true. And what contextual factors, governance, community engagement, provider incentives enabled better performing LMICs to overcome these challenges? So I'll comment on that, but I think Dr. Yemen SRH's presentation also provided some examples and things to consider, particularly in this rapidly changing financial framework or settings, as Dr. Yemen SRH mentioned. So the reality does remain stark. I think, that's why we're here. There's a lot of opportunity for improvement. I do think that there is significant promise in the idea of integrating particularly, I think, contraception into some of the maternal and newborn health continuity of care visits, antenatal care, postnatal care, nutrition, well baby, and immunization visits are all opportunities for health providers to screen for women's fertility intentions and desires and offer services in alignment with those intentions. But Luam does highlight that the continuum of care does, at least in Ethiopia, does tend to be low. It is often low in other settings as well. And I guess what I would highlight is, well, the continuum of care is relatively low. Only 20% of women complete all the visits. A much higher percentage of women do complete at least one postnatal care visit, well baby visit, immunization. And so I think, although it's always a challenge to identify what can be offered in a limited amount of time without overwhelming providers or women, it does highlight the importance of making sure that those key services are offered as part of all of those visits to capture women when they are coming back, and to not save those really critical services for just one postnatal care visit or something along those lines, because we know that women are not necessarily able to complete all of these visits. I actually maybe we'll turn it over to Dr. Yemen SRH to comment, or Dr. Rosaline to comment on the last piece about contextual factors, because I think they both provided a little bit more detail in their own presentations and might want to build on that a little bit, if that's okay.
Okay, thank you, Dr. Lini. Maybe if there are questions that our sister from Uganda can answer. Dr. Rosie, do you have questions to respond?
Yeah, I think
Yes, thank you.
there are sorry, Dr. Rosaline. There are about 3 questions at the top that were directed to Dr. Rosaline. Maybe we can maybe summarize that at once, just to save our time. So the 3 questions are like this. The first one is, how can PHC systems address cultural stigma or resistance to SRH services while maintaining community trust? The second one is, what is the policy and regulatory framework for providing post-abortion services? And how is being considered in the integration journey. And the third one is about disability mainstreaming and integration in SRHR. Thank you, Dr. Rosalie.
Okay, thank you so much. This shows that most of us were attentive. I'll start with the cultural context. Uganda is a country that has various cultural norms, and in as far as SRH is concerned, people perceive them differently. So what happens to that the government can maintain this community trust is by looking at the most appropriate cultural norms that can be built on and discouraging the other cultural norms that are detrimental to SRH. For example, in some communities, they say that when a woman is to plan using natural family, using traditional means of childbirth, spacing of childbirth, they simply get, there's some herb that they have to hang up, and then she will never produce until that one is removed, which is wrong. So we do a lot of community outreaches, community sensitization, demystifying the very dangerous cultural norms and promoting the positive ones. The positive ones are in child spacing in some community, like the pastoralist community. When a woman has had her baby, the culture has it that the man has to move to another community until when the baby is 2 years, then he's allowed to come back. And this woman who has to stay in the hut of the mother-in-law for the 2 years so that she's protected and protected from any sexual intercourse to be able to conceive before the baby is 2 years. So we tend to using different approaches to encourage those positive cultural norms and discourage the positive one. And this is done using community entry leaders who are gatekeepers to make sure we maintain our trust with the community. In as far as post-abortion care is concerned, I want to say that Uganda, the provision of post-abortion care is governed by complex policy and regulatory frameworks. This, in a way, seeks to balance both legal restrictions on abortion with the aim of reducing maternal mortality and morbidity. So as a country, our legal framework permits that abortion can only be done when authorized by law, which is generally interpreted to mean that when the life of the mother is in danger. So despite the restrictive abortion laws, PAC per se are legal and are provided in both public and private health facilities in the country. And Minister of Health has the standards and guidelines that fully support the provision of PAC and healthcare services in the different communities. Therefore, the efforts that we have made to integrate PAC into primary health care is to improve accessibility, to help us reduce maternal mortality. And this includes training of health workers, the midwives, the nurses on how to manage post-abortion and ease management, but also task sharing between physicians and midwives that has been promoted in the country. And now in self-care, we have post-abortion care as part of the components of self-care that encourages women to actually report if they have had abortions without any fear, and the different roles that they can play in ensuring that they are safe. The last one, I seem not to have gotten it well, but I think it is generally integrating SRH. We have a guideline, which is integration of sexual reproductive health into PHC. And this looks at strengthening the training programs in the country, updating equipment and protocols, addressing stigma and legal clarity. So in primary healthcare per se, SRH is one of the key components that the communities are being informed about. And we have hotlines, call centers in the Ministry of Health and some partners. So those call centers are used to continue giving the right information to the community. And in a way, we are integrating SRH into the different programs in the country. Thank you, and over.
Thank you, Rosalind, for providing answers to the questions which were summarized by Bru. So, Bru, if you have summarized some of the questions to forward to Ms. Yemisraj, can you tell us if you
Sure.
have summarized those questions, please? Yeah.
Thank you, Dr. Awaka. I think I don't see any questions that's directly guided to me raise this question to Semstrach. So
Okay.
the question is like this: how government and government agents are working to strengthen the current SRH problem, like rural areas faced severe shortage of SRH providers and weak HMIS systems lead to underreporting of SRH indicators like GBV, encephal abortion complications, etc. So if you can respond to this question. Thank you.
Okay. So is it to Yemisraj or to all of them?
Yes, I think any of the panelists can comment
Okay.
on this.
Okay. Okay. Any volunteer from the panelists?
I can take it, Dr. Awad.
Okay. Yes, Yemi.
Thank you. I think this is an important question, and perhaps I'll just take it a little bit backwards in terms of the issue of contextualizing SRH programs at community level. Dr. Rosalind has also reflected on that. And in my presentation, I have also really addressed the issue of stigma, resistance, and cultural sensitivity are key challenges for SRH programs in general. That's why it becomes very important that SRH is integrated into community-based programs and overall primary healthcare, because that will present a strong foundation for programs which allows for communities to engage with providers, to build trust, and to be able to ask questions that could limit use of services. Another aspect of contextualizing is in terms of making it work for the context. Just let me take the example in Ethiopia, where we do have the National Health Extension Program, which is implemented in all the regions. However, the level of implementation is not consistent due to the geographic context. For example, in pastoralist communities, because of the behavior of pastoralist communities, the health extension program could not be implemented the way that it has been implemented in agrarian areas. So as we think about contextualizing, it's also about really making it work for the people and, meeting the people where they are, not expecting the people to come and take the services. So that's also one key lesson from Ethiopia. The issue around, how do we, expand SRH programs in rural places and address barriers comes also again with community agents and, community-based, community-based health extension workers, or, the CHOOS or other models, whichever it is. They can also provide health education and teaching the communities about issues that matter to them. So they're not only providing services, but as they go house to house, they can also educate people. And in cases of GBV and other harmful traditional practices, the community health workers can be instrumental to coordinate with the law enforcement and to ensure that women and girls are protected in their communities, and also to really collaborate with communities to safeguard, people who are, vulnerable, including women and girls. So they have multiple purposes, and that makes it even more important to have, community-based agents and, the whole community-based approach for increasing access for SRHR services, but beyond that.
Okay, thank you, Yemi. Is there any other question, bro?
Yes.
Okay.
Thank you, Dr. Awaka. I think this question is directed to Dr. Linie, and it's asked by a participant with name Luan. So the question is like this: while the gap between the ideal of co-located SRH PHC services and the reality of fragmented care remains stark. Have any LMIC successfully improved continuity of care by integrating SRH into routine primary health care service, such as immunization visits? For instance, Ethiopia's PMA data from few years back showed only 20% of mothers completed the continuum of care. What contextual factors, example, governance, community engagement, or provider incentives enabled better performing low and middle income countries to overcome this challenge?
Okay,
Yeah,
thank you.
thank you for that question. I think I had actually already answered that by noting, I think that part of what we had discussed is making sure that services are really available as often as possible, as opposed to perhaps within specific visits within the continuum of care, as few women do actually complete the entire continuum. And then I had said that Dr. Yemen Sarash and Rosaline had spoken to some of the contextualization and factors that had made them successful. I do think, I would just note governance. I think we all know how important government commitment, both at the national and regional or zonal or state level is. I think it's almost an unsaid thing. We know that most of these programs really cannot succeed without government ownership and buy-in, and so it really is critical. If it's okay, I'd like to actually just add on a little bit to the last question that Dr. Yemesarash had spoken to, and I wanted to just highlight about the importance and thinking about HMIS systems for data. And I just wanted to note in terms of importance of government and HMIS is thinking about for each country, who are the people who are sort of in charge of the HMIS? And by that, I mean, who is building those systems, who is designing the indicators and deciding what questions are asked and at what level of healthcare? And are there people with SRH expertise who are in those groups or in those meetings? I think frequently the answer is no. And maybe I'm wrong, but I think having people with SRH expertise helping in that process can really help with integration, because they can help inform what indicators are being collected and at what level. So if, for example, you want to know about availability of GBV services or curable STI services, and those are not in your standard HMIS indicators, or perhaps they're only asked at higher level facilities, then you may not have the information that's necessary to really understand the progress you're making in integration. And I just really want to highlight, I think, how important HMIS systems will be within this new, era of potentially reduced international investment, and really thinking about ways to make sure SRH expertise is in those rooms.
Thank you, Dr. Lini. Any other question? Maybe final
Yes.
question? Yeah.
I think there are a couple of questions for Dr. Rosalie from some of the participants. The first question is like this. Your points on integrating SRHR into PHC were compelling. I'm particularly interested in getting practical examples of social accountability in action while Uganda integrates SRH into PHC. Would it be possible for you to share about Uganda's experience in using social accountability to support the integration of SRHR within their PHC system?
Okay, Rosalind, over to you. Dr. Rosalind, we are not hearing you.
Sorry, I was speaking while mute.
Okay.
Thank you so much. I appreciate the questions that have come about social accountability in Uganda and how our sexual reproductive health and rights are integrated in the primary health care. First of all, social accountability in Uganda We use it because it encompasses different mechanisms through which we engage the citizens and the health service providers on policy issues, transparency, responsibilities, and of course, how to improve our service delivery. So in the context of sexual reproductive health, we do community participation, like I said, community participation in monitoring health service. We have what is locally known as the barazas, where communities gatherings are convened and a topic of concern is presented to the community and they give feedback. It's from that feedback that civil society can use that to advocate for particular changes. For example, there's one particular community in the West Nile region where women were giving birth with the traditional birth attendants and shunning the health facility. So one partner took up social accountability mechanism and was convening communities and asking them why they don't go to the facilities. And the reasons were that the health workers were not friendly, they lined for long, and they don't get the type of services that they wanted. So that the civil society used that to hold government accountable. And I want to say that by the end of some good months, the government managed to improve by equipping the facilities, having qualified health workers in that particular area to be able to offer services to the community. So our community-led accountability models has really worked. And also we do youth engagements where we have organizations like Reach Our Hand that has implemented a lot of youth-led social accountability through Mob Flash, through many mechanisms. And that holds government accountable in that the young people are demanding for services that can better meet their needs. So those are the small examples I can give in social accountability in Uganda. But I saw another colleague asked about disability. The question was, how have we mainstreamed disability issues in SRH? Uganda has made significant strides in integrating disability. And because of the many concerns from persons with disability, government took it upon its responsibility to continue offering disability-friendly services. And before even doing that, there is a national policy on disability, which underscores the government's mandate in promoting and protecting the rights of the persons with disability. Of late, advocates have demanded that every health worker be taught like sign language, because persons with disability, more especially visual impairment, find it hard to communicate their SRH issues because the health workers are not trained on how to interpret what they want to tell them. So they are demanding that every health worker should be trained on sign language. But also the Constitution of Uganda stipulates that we need to empower and provide equal opportunities to persons with disability while reinforcing the importance of social inclusion in all sectors. So all these are small attempts that the government of Uganda is trying to do in order to have social inclusion in our SRH services in the Ministry of Health. Thank you very much, and over to you.
Thank you so much. I think for the sake of time, let me take a few minutes just to finalize, this webinar. So far we have seen, the global perspectives from Dr. Lini, and also, country perspectives from Uganda by Dr. Roslyn, and experience from Rwanda, Kenya, and Ethiopia, from Miss SRH. So those experiences, I think the slide definitely, I'm assuming that it will be shared, to the participants, and you will have the resources to read. Just, to wrap up our discussions, we have been actually saying integration of SRH into primary health care unit is really very important. Maybe just to summarize some of the benefits why we are really saying that integration is important. One, integration brings improved access, which brings care closer to rural and underserved communities. By integrating services, especially SRH, into primary healthcare units, we will have greater efficiency, whereby we minimize fragmentation and maximize use of resources. And we'll have also continuity of care, where facilities will have seamless service delivery through referral systems. We'll have also the benefit of equity and inclusion, where it ensures dignity and rights for all, especially marginalized groups. We'll have also the benefit of health system strengthening in a way that builds resilience, responsiveness, and client-centered primary healthcare systems. It also empowers individuals, especially women, girls, and youth, to make informed reproductive choices. Moving forward, what key priorities should we focus, in the future? One, from the various discussions that I've got, is the policy integration, which countries should institutionalize SRH into primary healthcare policies and essential health packages. And second thing is capacity development of health workers. The health workers should be trained at all levels in equity, respectful SRH, and service delivery. And the other way forward is the community engagement. We have to engage the community as we integrate SRH into the primary healthcare units, which will help us foster local awareness and demand through participation. And the other important point is data and evidence, which we have to leverage robust monitoring systems to track progress and improve services. Partnership, as Yemisrach elaborated a bit, especially in the context of Ethiopia, we have the three ones: one plan, one report, one budget. I think other countries can learn how Ethiopia brings all the three ones together, which will foster actually the cooperation and collaboration with civil society, use networks, and the private sector. And the other important point, to integrate SRH into primary healthcare is to make sure that there is sustainable financing mechanism. To do that, we have to advocate for long-term equitable investment in integrated SRH services. There are different experiences from different countries. So saying this, I would like to thank the three panelists, which gave us really very elaborative insights, and the presenters, the audiences, for your patience and for your understanding, for your participation. I commend, you follow and attend this monthly webinar. And maybe you can also share to your colleagues, to the partners. This is really a very important forum, and I appreciate the efforts of the primary healthcare unit, in Ethiopia, especially the organizers of this webinar. So thank you so much. Have a good afternoon.
Thank you, our moderator. That was great of you as well. We appreciate you so much. And Public Health Institute, we really appreciate.
Yeah.
Bye, everyone.
Thank you so much, Dr. Awaka and all the panelists. It was a wonderful session. So thank you for all the participants as well for your active engagement. And we would like you to ask an apologies for the technical glitch. And thank you for your patience and rejoining for this important session. So please stay tuned. So there will be continuing sessions in the next months as well as it's a regular session. So these 3 months we will be talking about the integration of different services in primary health care. So the next will be nutrition, and then we'll talk about the whole integrations, service integrations in primary health care. So stay tuned, get registered, and follow our site so that you could get updated on these issues. And to continue these discussions and momentum, we have this global PHC platform at the Institute. So the link is shared on the chat. So please join if you haven't already joined. And also if you have joined, please get engaged and interact so that you could learn from each other. So have a good evening, afternoon, and morning for everyone. So thank you so much. Thank you, everyone.
Thank you. Thank you so much. Have a good evening.
Yeah, thank you, everyone. Have a good evening.
Thank you.